Influenza, we all know it's the highest epidemic across the globe. We get an annual infection rate of around 5 to 10% in adults, and almost 20 to 30% children are affected annually by influenza. There are three types of viruses, A, B and C. A and B are known to cause human outbreaks, whereas the C is less commonly seen with human infections. There's another thing that we should be aware of is bird flu, the animal influenza. You must have read in the papers about so many chicken being killed in China or so many chicken being killed in Andhra Pradesh. And what is that kind of an influenza? That's basically an animal influenza. And we have two types of common animal influenzas, that is the swine flu, that is not H1N1. We are wrongly labeling our H1N1 as swine flu. And you have the bird flu. Now, these viruses, the animal viruses, are distinct from humans. They don't really infect humans. But if there have been instances, there have been around 500 cases reported across the globe, starting from China, where these, as an occupational hazard, these people have been working in the farms, they've been in touch with these infected animals, and they've got the disease. The thing is, these animal influenza does not spread human to human. So that's the reason why people are not so worried about animal influenza. So there have been 36 cases of human to human spread of animal influenza, but it's something that is still not worrisome. And this animal influenza, the predominant one is H5N1, and what we call as H1N1 is the human influenza. Now, if somebody gets human influenza versus bird flu, how do you identify? Human influenza can spread very rapidly. That's how we get these pandemics. Whereas the H5N1, that is the animal one, it spreads very slowly to humans, but it's fatal, almost fatal. So all these 36 patients who they had a very morbid disease. Now, how does influenza present? It either comes to you as a seasonal influenza, it comes to you in a pandemic form, or it comes to you as influenza due to animal viruses. Now, I've already discussed the animal virus, so I won't go into that. But we'll discuss about seasonal influenza and pandemic influenza. Seasonal influenza, we know that influenza has got two antigens, the H antigen and the N antigen, and various permutation combination of these antigens gives us the various types of viruses. So we have influenza A, we have H1N1, we have influenza A, which is H3N1, so you have different combinations. Now, every year we get influenza. Why do we get? We already have antibodies to influenza, yet we still get influenza. It's because of these continuous permutation combination that gives you little bit of difference mutation, and that's known as the antigenic drift. And this is how you could see the seasonal influenza across the globe. And you have various types which are currently prevalent. You have the H1N1, that is influenza A. You have the H3N2, that is influenza A again. And there are two types of B viruses currently prevalent in the community. So your seasonal influenza is caused by 4 types of viruses currently. So even if you suspect influenza and you send H1N1 test, you may get it negative because you may have the other influenza which is causing the disease. So when you actually ask for a test, you must ask for H1N1 PCR. You may have to do influenza A and influenza B and identify it. So when is the flu season, we say? In the northern hemisphere, when I talk about northern hemisphere, I'm talking about the temperates, the European countries. Their flu season is in the winter, so it's from October to May. Southern hemisphere, again it's in the winter. So for them, winter is April to September. Whereas for us, it's year-round. Influenza is there entire year. In fact, we have predominant influenza during the rains. This year also the influenza epidemic has actually come in April and May. So we have it year-round. Now, why is it important to know the season? Because when you get a vaccine, you're supposed to give before the season starts. So in the northern hemisphere, they'll give it before the season starts. So they'll probably start in September, August or September. So you need to know which vaccine to give. Now in India, I'll come to the vaccines later, but it's very difficult to predict what time to give the vaccine. So that's how the influenza is. So as you can see the blue line, the temperate countries, it's November to April. All year round is the tropics, that's where we stand, and the southern hemisphere is in the April to November. Now we are talking about pandemic, and we are worried about the pandemic, that is H1N1. Now, what is a pandemic? It's a completely new strain to which none of the people across the globe have any immunity to it. So it's a completely new strain, and it starts spreading so fast that millions of people get affected in a span of short time. This is known as antigenic shift. Now, if you look at real pandemics, there have been actually 4 pandemics in the last 100 years. And the latest one was the 2009 H1N1, which started in Mexico. Influenza has been described right by Hippocrates earlier in 2400 years back. It must be even earlier than that. But the first documented pandemic was in 1580. And subsequently there have been 31 documented pandemics. The most lethal was 1918, lasted for 2 years, and it's supposed to have killed 50 to 100 million people. So that was the seriousness of the pandemic at that time. That was a Spanish flu pandemic. Why is H1N1 called swine flu? Did we get it from an animal? Did we really get it from pigs? Then it should have been actually animal influenza, and we should have been worried if animal influenza, as I told you in the earlier slide, it can be pretty fatal. What the laboratory found is the genetic material was very similar to those found in pigs, but it also had the similar genetic material found in human influenza, and as well as genetic material found from bird influenza. So basically it's a quadruple ressortment virus. It's not a swine flu, it's a misnomer, but because it's been so famous as swine flu, people have started using the term as swine flu. So actually it's known as the novel H1N1 pandemic virus. Now this H1N1 started in 2009. In April it started in Mexico. Now Mexico is thousands of kilometers away from India. By May this virus was reported in India. By June 30,000 cases across the globe in 74 countries, and by November 206 countries affected. How did it spread so fast? It's because of air travel. People have been traveling from one country to the other, spreading the virus. That's how the pandemic really spread so fast. Initially, they didn't have a vaccine for this. So, though it started in April, the H1N1 vaccine actually came in autumn 2009. So, there was no vaccine earlier. Earlier, the vaccine that was developed was separate as compared to the seasonal influenza vaccine. So, if somebody needed influenza vaccine, they had to take influenza separately and they had to take H1N1 separately. Now what happened? 2009 is pretty long time back, it's almost 6 years back. What happened is this virus started getting integrated into the regular influenza, and it's now behaving like a seasonal influenza. So when now we talk about H1N1, we are in the post-pandemic phenomenon, and it's part of the circulating influenza viruses in the community now. So it's no longer a pandemic, it's a post-pandemic phase. So now we have H1N1 as a seasonal influenza, we have H3N2 as a seasonal influenza, and we have the type 2, the B viruses, which are now as a seasonal. Till now around 14,000 deaths have been reported with H1N1. Symptoms of H1N1, if you ask me, how do we identify this as H1N1 or this is influenza? We cannot. It's the same as seasonal virus. Sudden onset fever, muscle aches, headache, cough, sore throat, vomiting, cold. Children may come with diarrhea also. Typically lasts for a week, and then sometimes this cough may last for 2 weeks. So what is important to know is who is more prone to get severe influenza. I tell you, the most abused antimicrobial right now is Oseltamivir. We have children who will get cough cold. Nobody's tested for influenza, given Oseltamivir. Next month comes back with cough cold, again given Oseltamivir. So you would have this child getting Oseltamivir probably 6 times in a year. So it's one of the most misused drug that. So we really need to know the severity. Who is more prone to get a severe illness? Those are the ones that we need to treat, not everybody. Adults more than 65 years of age. Children less than 2 years. We all see viral pneumonias. We all see these children who are chintus, who require oxygen by hood. None of them actually require oxygen by mask. So they are all these infants. People with underlying conditions. I always tell my residents, if you have a cardiac disease, vaccinate them with influenza. You don't want a congenital heart disease coming with an influenza and being in the hospital for 10 days. So heart disease, lung disease, kidney disease, liver disease, asthma, immunocompromise. These are the patients you need to watch out for severe influenza. So these are the patients, if you know high risk group, you know these are the ones I need to treat. And who is more prone to get influenza? It's children. So influenza is commonest in children. Adults are less prone because we have little immunity. What are the diagnostic tests for influenza? We have actually the diagnostic test is not a blood, it's not an ELISA. If you're going to do a blood ELISA, you need to document a 4-fold rise in the antibody titers. If you're going to wait for 4-fold rise after 2 weeks, by that time the virus has either killed the child or the virus has disappeared. So you can do viral cultures. Viral cultures are all research based. So what we have is a throat swab. Nasopharyngeal aspirate is also not easy to do practically. So we actually do a throat swab. And we send the throat swab for either a rapid influenza test, which you can get in a matter of minutes, or you could do it with a PCR. Now when you ask for PCR, there are labs which will ask you H1N1, you say yes. Influenza A, you say yes. Influenza B, you say yes. Each one costs you 4,000. So you're spending 12,000 rupees doing an influenza panel. So, and if you say, oh, it's not H1, all patients also know about H1N1, but they wouldn't know about influenza. So you say, oh, it's not H1N1, they're very happy. But if you say this is H1N1, they panic, even though it's the same influenza. PCR gives you a result in 24 to 48 hours. The problem is, you send the test, do you isolate the patient before the test comes? That's an issue, and that's why most of us actually don't land up sending the test and we just land up treating the patient. So if we are talking about isolation in influenza in a hospital-based practice where you have general wards or you have private wards, how are you going to isolate these kids? Most of your kids in the hospital are with a respiratory illness. You would be either cohorting them all together in one particular room, all the respiratory patients, that's one way of cohorting them, or you keep separate rooms for everyone, which is not possible. Now you may have cohorted all respiratory illnesses together, you may have had a para-influenza and an influenza, you would have an adenovirus all cohorted together and transmitting illness to each other. Okay, so that is also not a solution. Sending the test and you didn't cohort means you had it spreading out in the general population and spreading to everybody else. So this is one area which is a grey area where guidelines are not very specific. It's very easy to put it on paper that you wear an N95 mask, you wear a gown, you wear a cap, go like a spaceman into the room and dispose of everything before you come out of the room. It's very easy to say, but to do it practically for each and every individual patient becomes very, very difficult. Isolation practices, today if you don't send H1N1 and this patient somebody else saw and sent H1N1, you would be in trouble. Why you didn't send, why you didn't isolate. So there are a lot of issues. So that's the reason what happens is we overtreat. We said, okay, let's not send the test, but we'll treat the patient. There has to be a rationality about what you do in these patients. What we do, if this patient comes with cough, cold, fever, we don't know whether it's influenza, para-influenza, paramyxovirus, it's adenovirus. We tell them, don't send the child to school, keep the child at home. Preferably keep the child in a separate room if possible. Try and avoid as many visitors as possible. And in case he can wear a mask, if he allows you to wear a mask, give him a mask to wear. Okay, that's routine isolation practices, practical aspect that you give it. You always tell the parents that he's not a sick child, he doesn't require Oseltamivir. He's not in a high risk group, he doesn't require Oseltamivir. He allows you to wear a mask, give him a mask to wear. Okay, that's routine isolation practices, practical aspect that you give it. You always tell the parents that he's not a sick child, he doesn't require Oseltamivir. He's not in a high risk group, he doesn't require Oseltamivir. Some parents may ask you, but we want to send the H1N1. So if they insist, you could send the H1N1 test. If it comes back positive, you ask them still that, look, he's still not symptomatic in the way that he requires hospitalization. There's no need to take Oseltamivir. Okay, so it's difficult to, I have had patients this season whom, the moment I said it could be flu, they said we want an H1N1 test. Okay, get it done. And then the test comes positive and they come running to the clinic. Now this test is positive, now what do we do? And at that time, Oseltamivir syrup formulation was out of stock in Mumbai. So we only had the adult capsule 75 milligram and you want to give to a 10 kilo child. It became so difficult to get them to get the capsule, pulverize it, all that. So it's really a problem on OPD basis to diagnose H1N1. It's a headache actually to diagnose H1N1 and then say don't treat. Because they read it all in the papers, one person died, second person died, third person, and they say, why are you not treating? So you be very rational when you are sending this test, which patients you want to send. Send it in patients who are high risk group. Okay, so remember the most important slide was the severity of influenza. Children less than 2 years, more than 65 years, and all those ones with associated conditions. Uncomplicated influenza-like systems that I told you, no test required, don't send the test. All hospitalized patients, you must send the test, especially ones with the respiratory, high-risk conditions you must send. And in conditions in which there's going to be a risk to the healthcare worker. How does influenza spread? It's through droplets. If you think somebody is coughing today in the audience, somebody did cough, and I think that person is going to be very embarrassed because I pointed it out. But if somebody coughs in the audience, do you think we are going to get the virus like this? Is it airborne? If it was airborne, the whole population would have been affected in a span of days. It's more through fomites. We coughed, we kept our hand here. We touched this table. Then somebody else came and touched this table and put his hand onto the mouth or nose or eyes or whatever. That's how it spread, through fomites. So it's basically through droplet. It's not through it. Coughing and sneezing can give you particles, but they are not large enough to actually go into your system and cause the disease. It's more of fomites. And that's the reason why we talk about hand hygiene in influenza. And we talk about alcohol, those dispensers and everything. So it's basically through fomites. So if you're coughing, the cough etiquette comes into the picture. You need to cover your mouth with a tissue or with a handkerchief. If you have a tissue, you need to dispose it properly. Just don't leave it on the table there. And then, somebody else touches it, or that's how it spreads. And the worst thing that I've seen in the OPD practice is the mother comes and she says, "Bahut sardi hai," and then she'll clean the nose, remove that sputum or mucus, and wipe it on her cloth. I think that all of us have seen that. And we really need to scold the parents for doing this, because that's how it spreads. That's how it spreads. It can remain, this virus can remain on the surface for almost 24 hours. How long is a patient contagious? 5 to 7 days. Those who are immunocompromised are very sick, even up to 10 days. In fact, there have been case reports where people have isolated the virus up to 90 days also from a patient. But usually 90% of the community, 10 days, 7 to 10 days. So that's why when you say don't go to school, it would be 5 to 7 days. How do you protect? One is vaccination, but when you talk about vaccination, we said this is seasonal influenza. Annual rate is 30%. That means we are talking about annual vaccination. You try and avoid close contact with people who are sick. We can't do that. We are always dealing with sick patients day in and day out. Tell the patients, stay home when you're sick. Cough etiquette, what I told you. And always sanitizers that can help you. So these alcohol-based sanitizers, tell them to keep it with them. They help you. In fact, I remember once I heard a talk on UTI and toilet etiquette. And it was the most hilarious talk I had heard about how toilet seats are the ones that cause UTI. And believe me, after that it's been very difficult to sit on a toilet seat. Because when you hear the talk about how these germs are sitting on the toilet seat, how they are spreading, and all that. So similarly, when I bet next time you see a mother who does this and onto the cloths, you'll be disgusted. Now treatment, we used to have amantadine earlier. Now we don't talk about that because of resistance. We have Oseltamivir and zanimivir. We don't use zanimivir in India. Basically it's a nebulization. You don't give it in asthma patients. So we only have Oseltamivir. And if we are going to use left, right, center, we will talk next year about MDR influenza. So we need to be very rational when we use. Now the question comes, books mention we have to use this drug within 48 hours. We say patient is not toxic in 48 hours, he is not sick. He became ill later, we didn't use it at that time. So does that mean that every patient who comes in 48 hours we use? No. A patient who is not in the high risk group doesn't require it. A patient who is in a high risk group but still doesn't have severe illness will require it. So the only slide of the entire talk was that high risk group. If you remember that, you'll know how to manage a patient with H1N1. So every patient who is in the high risk group, you have to treat. Patient not in the high risk group, uncomplicated, don't treat with Oseltamivir. These are the various doses that are there. I think everybody has it on the net. You don't need to remember the doses. But I did find a reference, because for pediatricians it's always easier to remember milligram per kg. It's very difficult for us to remember weight bands. So I did find, and especially where Western literature says that Oseltamivir should not be used in children less than 1 year. And we are the only ones across the world who are using Oseltamivir in children less than 1 year. So we need to have a guideline as to what dose are we supposed to use. So I did find a reference of 2 milligram per kg twice daily in children less than 1 year. But not more than 1 year. After 1 year you have to take the weight bands and treat these children. I mean, it became so difficult for us, 75 milligram of nat flu, and we had to pulverize the capsule and tell the mother, okay, now you've pulverized it, now you take 1 pudi in the morning and 1 pudi in the evening. And syrup Oseltamivir was out of stock. Prophylaxis recommended again for people who are in the high risk group. Suppose today somebody in your family has H1N1 or influenza, does that mean all of us are going to take? Yes, as doctors we may have to take, because if we get influenza we'll spread to another 100 patients. So we may have to take, but not everybody in the family requires it. The ones who are in the high risk group would require the influenza, and most important is isolation of the patient. So again, who should receive the Oseltamivir? Those who are prone to get severe influenza. Pregnant women, they have to take, because pregnancy is one of the factors of causing fatality. You read it in the papers, this pregnant woman died and that pregnant woman died. Patients who are on aspirin, because of the chance of race syndrome, you have to give them the antiviral, and all hospitalized patients. So whoever's got severe influenza, you have to give them Oseltamivir. Now the question is of the vaccine. Vaccine is one topic I try and avoid as far as possible, because it's so much merged with commercial interests. Even when I look at recommendations of the vaccine, and if you look at conflict of interest, you would find conflict of interest with most of the people. There would be either somebody from the pharma sitting in the committee, or somebody who is brand ambassador of the pharma making a recommendation. So you really get worried about, at least I do get worried about talking about vaccines. So influenza vaccine, now if you look at AAP says immunize everybody. If you look at how much have they achieved universal immunization, to the tune of 40%. So 60% of their population still doesn't take influenza. What does IAP say? IAP says high risk children. So the high risk group you need to. So again, it's the same high risk group: immunocompromised, asthma, heart disease, lung disease, renal disease, liver disease, all of those you need to give. And all pregnant women, which I pretty much agree. I think that we should be giving, at least let's start with the vaccine for the high risk group. We are practically just not using the vaccine. One pharma company had actually to destroy the vaccine before this season started. And when the season started, the vaccine was out of stock because they had destroyed the vaccine. We didn't have the vaccine in the market. So at least start with the high risk group. And of all the high risk groups, the one that I see most commonly affected are the cardiac diseases, congenital heart disease. All of you all must have seen congenital heart diseases. Most of these kids are on oxygen with a pneumonia. So at least start with vaccinating these kids. Now what about children less than 6 months? The vaccine is not recommended for children less than 6 months. And these are the groups that is the highest risk of getting influenza. So if these kids cannot be immunized, you immunize the family, because they are the ones who are going to be in touch with the kid. And if you immunize the family and the family is vaccinated and immunized, they are not going to spread it to the child. So this is known as herd immunity in a way. So you immunize the family for a child less than 6 months. Now the types of influenza vaccine, I told you there are seasonal influenza, 4 viruses currently prevalent. So we need actually a quadrivalent vaccine. What we have in India is trivalent vaccine. Abroad they do have started, I think 2014 the quadrivalent vaccines came into the picture. So we have 2 for influenza A, that is H1N1, H3N2, and 2 of influenza B. We have 2 types of vaccines. We have the live vaccine, which is a nasal vaccine, and you have an inactivated vaccine, which is the injectable vaccine. High risk patients, you prefer the injectable, not the live vaccine. There is a slight risk of GBS with the live vaccine. It's 1 in 1 million, but there is a risk. So live vaccine absolutely not in children less than 2 years, in pregnant women and those with high risk conditions. So it's going to be practically the injectable vaccine. Doctors, yes, we could take the live vaccine, the nasal vaccine, because we are not a high risk population. Schedule of vaccine, anybody less than 9 years of age. So you start from 6 months, but the first time you're giving the vaccine, you need to give 2 doses, 1 month apart. But beyond 9 years of age, you need to take once a year. So you take 1 dose a year. And as I told you, less than 2 years, don't use the live vaccine, use the injectable vaccine. When do you give the vaccine? All your recommendations are before the peak season. So northern hemisphere before the winter, southern hemisphere before the winter. In India, it's all year round. Peak is in the June, July. Now, how do we know which vaccine to give? What happens is, in India, the vaccine that is available is similar to the northern hemisphere strains. And we actually give the northern hemisphere vaccine. Now, WHO changes the vaccine every year. They have a meeting in February. They collect information from all their labs across the world to know what was the prevalent virus last season, what is the likelihood of the prevalent virus this season, and then they say that the vaccine should contain these viruses. Production starts in March. By the time the vaccine comes, it's in time for the season for the northern hemisphere. For us, the vaccine comes much later, and we actually have to give it just as soon as it arrives. So we don't really have a season where we'll give the influenza vaccine. How effective are these vaccines? Around 70 to 80%. It's because it's a permutation combination, it's a mathematical calculation of the prediction of the future strain. It's not at the time of the prevalent strain that the vaccine has been created. The vaccine has been created before the strain started circulating. So it's a very predictive vaccine. But still, it's got a correlation of around 70 to 80%. And for 2015-16, this is the vaccine that is recommended. We have the influenza A, H1N1, influenza A again, which is H3N2, the place from which this virus has been isolated. And the B is the two, one is the Australian and one is the Thailand. So these are the ones. The Australian one in the quadrivalent vaccine has been added to cover the strains which are prevalent in northern hemisphere as well as southern hemisphere. So H1N1 now is in a post-pandemic phase. It's a seasonal flu now. It can be diagnosed by PCR rapid test. You give the vaccine in the high-risk group, at least start off with that. And you should use the antivirals again in patients in high-risk group and those who are more sick, but don't use it in community-based patients. Thank you very much.